Hello everyone, how are you all doing? Let me know if anyone can hear me. Perfect. Hello Sarah and Stephanie. Hope quarantine is still going okay. Kylie, how's it going? Let's give it a few minutes before we get kicking off with the rest of our ER stuff, and then we can get into the toxicology stuff. I'll be interested to see if the Friday afternoon spot is gonna hurt my viewership. I'm usually getting about 25 or so, but we'll see if that dips down at all. Anyone have any good quarantine stories to share? That's true. It's been really difficult to tell what day it is. I was just like, is it Thursday? And right now it's only Tuesday, so it's definitely strange. I don't think I've left the house since the last time I went to work at Nemours, so it's been almost 2 weeks. So it's great for the introvert lifestyle. Hey, Anna. Do you wear a mask at work? So I do if I'm in the IV room. So that way we can keep everything aseptic and sterile. But out in the central pharmacy, not so much. I haven't, at least they've not required us to start doing that yet, but I'll be interested to see once I go to work this week on Monday to see if that will change, so we'll find out. My husband decided to turn our apartment into a spicy pepper grow house ever since. Are you sure it's just spicy peppers? Not something else, maybe more clandestine. No comment. Okay, that's good. Yeah, I've not picked up any new hobbies. It's mostly just hanging out with the children, and we have a pretty sweet fort we set up on one of the beds. It has like pretty high back on it, and we have the covers all set up over that and everything. So a lot of time in the fort. Other than that, just playing outside and having a good time. The kids driven me crazy yet. You know, it depends on the day, on the hour. Just every day is a new experience, I think. But I love them all the same. I'm gonna start about a minute or so. I will never reveal that secret, Sarah. I cannot tell you. All you know is at least a business shirt on up top. Have I played Animal Crossing yet? No, I have not been playing any Animal Crossing. I was worried that would detract from my ability to get anything else done, so I'm abstaining maybe until a semester break pops up. If I do, though, we should like set up a share so all of the everyone can go to each other's islands. That would be fun. All right, so it is 12:30, and I'm going to go ahead and get started. Let's see. I did have one question on this. Oh, let me start recording. All right, so just to get started, so someone asked how much will we have to know about proper Bristojet use for the exam. I don't think I'll ask any questions about that on the exam. That is more for your benefit in terms of how to not make yourself look silly when you're out there. If you were ever asked to start drawing up meds or get meds prepared, you want to be able to make sure you're doing that properly. And so it can be a little hectic the first time you do it, but once you get once or twice in, then it's not so bad. But anyway, so any questions, just go ahead and pop them in the chat or put them up on the sticky board, and we'll go from there. So I'll finish up the ER section now, and then we'll get into the toxicology section up next. So anyway, without further ado, kind of the last smattering of topics here. The first one being hyperkalemia. This is a good one. I know most students, when they're on their ER rotations, will get pimped on this. And I've had many people come back and say, oh, thank goodness I remembered what you taught us about this and what they learned elsewhere. So looking at potassium, this is an important thing, not only due to patients with like renal dysfunction, but a lot of different conditions can affect serum potassium levels, things like acidosis and rhabdomyolysis, and all kinds of different things can cause disturbances in your potassium here. And so hyperkalemia tends to be one of the more potentially fatal ones, which is why it's considered sort of an emergent condition. If you recall our sort of analogy as cells being a salt-wrapped banana, right? So potassium having a really high intracellular content versus the extracellular content. You see how that makes sense if you were to have, say, something like rhabdomyolysis, where you have a lot of muscle cells are all dying off at the same time. You could imagine how that would release a ton of potassium. Or say you activate all the muscles at once with something like a depolarizing neuromuscular blocker like succinylcholine, for instance, right? And so this is so important because it helps to regulate function of excitable tissues in the heart. And if you have too much out there, you're definitely going to see risk for arrhythmias. I'm not going to get into all of the EKG changes because you'll learn that elsewhere. But the main thing is you want to make sure you keep it in this narrow range, 3.5 to 5 milliequivalents per liter, and that's a pretty narrow range as compared to something like sodium, like 135 to 145, fairly narrow here. And so because most of it is excreted in the kidneys, this is why I cared about it a lot from my standpoint, because medications can affect this, either causing hypokalemia or maybe causing hyperkalemia. We know things like your ACE inhibitors and your ARBs and things like that can increase it. So a lot of different things. Or imagine you have rhabdo that occurs due to statin use or something that can cause hyperkalemia. So a lot of different things that can induce this. Not only that, but you might imagine even things like increased intake. So there, I don't know if they have many of them out there anymore, but there were like salt substitutes they would have for patients with hypertension that they didn't want to have increased sodium intake. Instead, they'd use like potassium salts instead. And so that would be one source where people can get a whole lot of extra intake. Or maybe they just like bananas a whole lot and have gotten a lot of those. Just as a random fact, people talk about like, okay, well, bananas have a lot of potassium, but does anyone actually know how much potassium is actually in a banana? And so if you don't, it's roughly 1 milliequivalent per square inch of banana. So people talking about increasing their potassium, significantly with just bananas, it'd probably have to be at least like a 10-foot banana or something, right? But anyway. And there are more potassium in potatoes. I actually don't know the potassium content of potatoes. I am ashamed of my lack of knowledge, Emily. I'm sorry. But maybe we can look that up, perhaps. But anyway, so again, some of the things you're going to see here. And if you imagine some of the different changes that can happen in terms of EKG changes, you can see some here, like your peak T waves and whatnot. But certainly things like VFib, asystole, obviously those are not really compatible with life. So we'd like to avoid that if we can. Other things you may see include like some neuromuscular changes like weakness and paresthesias as a result, because your muscles are going to be pretty well affected by this, just like the myocardium will, right? So how we treat this specifically. So say you have your patient come in, let's say they were getting dialysis Monday, Wednesday, Friday, but they say, no, I don't want to do that. I'm going to go ahead and skip Friday. They don't monitor their intake very well, and then they come in Monday just feeling awful. having that weakness, those paresthesias, and then, now they're potassium like 7 or 8 or something like that, right? So that's a medical emergency. We want to do something about that. And so this is a good mnemonic that I like to tell students to help them remember the different treatment options that we have in terms of treating hyperkalemia. This is not necessarily the order that you have to give it in, but this is something just to remember the different ways that we can help to manage that. So I use the mnemonic CA big K drop, okay? What that means is calcium and albuterol, bicarb, you'll have insulin and glucose. It's important to give those two together. And then finally K-xylate, and then dialysis being the final thing there. Oh, let's see, we have our potato amount here. One average size whole baked potato contains 926 milligrams of potassium with the skin, or 610 milligrams of potassium without the skin. How many milliequivalents is that? I don't have the conversion down in my head, so maybe we can figure that out too. Anyways, let's get into the different options and see how this will affect it. So looking at calcium, that'll be probably one of the first things you can administer to these patients. And if you recall, we have two main varieties, right? We have calcium gluconate, calcium chloride. Obviously, if someone is like really kind of towards the side of having, say VTAC or something like that, VFib, or, they're actively coding, like this is where, calcium chloride might be the one you want to jump with, right? Because it's more potent in terms of elemental calcium. 1 gram of that is roughly equivalent to 3 grams of calcium gluconate, if you recall that 3-to-1 ratio. The main reason why we give calcium here, though, is to help basically kind of reduce that threshold potential for those cardiac myocytes. So basically it helps to reestablish the resting membrane potential that has now been affected by the potassium, right? So by the potassium being out of whack, that's changing your membrane potential. Calcium helps to restore that. Okay, so we call that stabilizing the membrane, essentially, to try to prevent patients from developing, any kind of significant arrhythmias. So 926 milligrams equals 23.7 milliequivalents. That's pretty good. I mean, if you think about a typical dose of potassium you give to patients, daily requirements is roughly like 1 to 2 milliequivalents per kilo. But yeah, if we were doing it as like a supplement, you typically do between like 20 and 40 milliequivalents. So yeah, you could just say, take 2 potatoes and call me in the morning and see what their potassium is doing. So there you go. Anyway, so you'll find that this typically is a little more beneficial in normocalcemic patients. Saving it with potato, yes. We're saving patients with potatoes, absolutely. Although it might be tough. I don't know if you'd have to like mash it first to get it through the IV, or what you'd have to do, but might be a little difficult. The thing with calcium, though, it's kind of a stopgap, right? It's something that's going to go ahead and keep things stable for a little longer until you can do some more definitive therapies. And so we're going to look at that in just a little bit. Usually a pretty short duration of action. So like I mentioned, it's kind of a band-aid on the situation, roughly 30 to 60 minutes or so. Ideally, if you'd have some kind of deep access, like a central line or something, calcium chloride will be preferable there, just because you don't have to give so much volume. But calcium gluconate can work just as well. Easier on the vein, so most often you'll end up giving that, especially if it's not like an emergent sort of situation. So, ways that we can try to shift potassium into the cell. So how can we do that potentially? This is, again, not going to fix the ultimate problem if the patients have way too much potassium in the entire system, both intra and extracellularly. But at least from an extracellular standpoint, we can shift some of that into the cells itself. And so this is where we can either use our beta receptor agonist. This includes albuterol and then terbutaline, and then bicarb. Those are the two big ones, right? So basically by activating beta-2 receptors, that does cause an inward shift of potassium. And in fact, if you recall, when we talked about like our pulmonology drugs, albuterol, one of the side effects you can see is hypokalemia potentially. It's a transient thing, but it's something that you can see occur with some regularity. For most patients, it's not a big deal though, right? But here we're using it to try to shift some of that in. Albuterol is nice if you have patients without IV access. So imagine you're out in the field or something, or EMS is taking care of the patient. This is a nice, again, short-term sort of countermeasure to try to get that potassium shifted in. If you have IV access, then maybe something like terbutaline can be used. So that's one thing. Keep in mind, though, there's some negatives to it, right? So, for instance, tachycardia and tremor are going to be pretty common with beta-2 agonists just due to the effects on the skeletal muscle and on the heart itself. And then you're going to see that patients who are on beta blockers, obviously they may be somewhat resistant to that, especially if they're on, say, a non-selective beta blocker like propranolol or something like that. Okay. And then with bicarb, typically you end up seeing that when patients are in an acidotic state, that does cause a shift of having potassium come out of the cell. This is really kind of nicely illustrated in patients with, like, say, for instance, DKA, right? So patients with DKA, they oftentimes will have very significant acidosis going on. Their pH is like 6.9 or something, right? In some severe cases, that will cause that potassium to shift out of the cells, and then they ultimately end up kind of peeing all that out. There's a polyuria that goes along with that, and so they actually end up becoming deficient in potassium because they end up urinating a lot of that out. But for patients who have total body excess of potassium, we can give bicarb, and that will help to bring the pH back to normal, 7.35 to 4.5 hopefully, and then shift that potassium back in. Most patients will usually get roughly 1 milliequivalent per kilo IV. For most, you'll cap that out between 50 and 100 milliequivalents in a dose, and then kind of go back through and see what your pH is. And most ERs are going to have, iStat, which is a device that can do point of care at the bedside readings of pH and give you an idea kind of where they're at. So it's something they'll do most frequently. Let's see. So then you have insulin and glucose. This will also work to shift potassium back into the cells, and ultimately what this is going to do is kind of help to activate the sodium potassium ATPase pump. It kind of gets it working in overdrive, so to speak. And again, we remember that the sodium potassium pump is really useful for helping to maintain that resting membrane potential, if you recall. Again, it's shifting these electrolytes against their concentration gradient. So it should be sending sodium out of the cell and bringing potassium into the cell, which is essentially what we're doing, right? In this case here, we're going to use 10 units of regular insulin along with 25 grams of dextrose typically, right? The glucose itself doesn't really do a whole lot of good, but we end up giving the dextrose along with the insulin because we don't want to bottom the patients out, right? We don't want to make sure the glucose doesn't go, they don't want to be hypoglycemic, then we have to treat that anyway. So 10 units of regular insulin. We only use regular insulin, and this is typically IV. We don't like longer acting forms because, again, it gets unpredictable at that point, right? We're looking for a kind of a short-term countermeasure. We're not looking for a kind of a long-term effect from this. And so with longer-acting insulins, you're more likely to see recurrent hypoglycemia, so there's issues with that. So using an IV dose, only use regular insulin. Rarely we'll use something like Humalog or Novolog, those really fast-acting ones, but that's the only kind of variation I would use with that. And then for some patients, it may require like a dextrose infusion in order to help manage that, so it just depends on how they respond to that insulin itself. So that's how we can shift it in, right? So we talked about how we can stabilize the myocardium. We talked about how to shift the potassium back into the cells. Now, how do we get rid of it? Like, how do you get the ultimate problem taken care of? That's like getting it out of the body itself. You could try diuretics, but that tends to lead to dehydration. It can lead to other electrolyte disturbances like hypomagnesemia and hyponatremia potentially. So instead, we can try to do some things to try to get rid of it more specifically. So for instance, with K-exolate, we have one way to do that. This is what we call an exchange resin. And the drug itself is sodium polystyrene sulfonate, or if you see SPS or K-exolate, this is what the drug is. And basically, you give this either orally, or you can give it rectally, potentially, depending on the patient's condition. And it will then take the sodium that's on that polystyrene sulfonate and switch it out for potassium. So the sodium will get dissociated from the drug, it will get absorbed, and potassium will be drawn out of the body through the GI tract and bind to it. And then you just poop it back out, right? This is a pretty slow process though. And so again, this is better for stable patients or maybe patients who you are going to have some time to work with, some hours. So not for the most severe cases of hyperkalemia, but it can be useful. So this is usually like an adjunctive sort of thing there. The ultimate way to get rid of this though is going to be dialysis, right? That's kind of the last thing. Usually within the first 1 to 2 hours or so, they're followed by about 1 to 2 milliequivalents per liter, which again, we're talking about going from 7 to 5, they're right back down to the normal range now, right? So that's pretty useful. And again, a lot of these patients may be non-compliant with their dialysis in the first place, so that's what they're missing. So just go ahead and replace that dialysis with what they missed, and then you should be able to get them kind of back on track, right? So that's it for hyperkalemia. Moving on, the last thing we'll talk about here is going to be anaphylaxis. I know we've mentioned this before, but I did want to kind of bring it up in terms of just kind of reiterating the points here. Again, we will see the anaphylaxis and allergic reactions can kind of run the spectrum, right? So it could just be minor itching and redness. It can go all the way up to full-on anaphylaxis, potentially with airway closure and things like that. Kylie asked, do you worry about hypernatremia with exchange resin? Typically not. If you're thinking about the total amount of sodium that's moving in compared to the potassium that's leaving, it's not usually significant enough to worry about. Or at least with things like the hypernatremia, you can see that even like a small bump is not going to make that big of a difference. Even if you had, say, a 2 milliequivalent per liter increase in sodium. That's much smaller of a difference than you would see with like potassium. So it usually is not a clinical concern, but you still could monitor for it there. So anyway, so looking at the common things we're going to give. So H1 antagonist, you know, is going to be pretty much a standard for the majority of patients to receive. So especially for mild to moderate allergic reactions, you're going to go with the H1 antagonist. All the way to the very severe ones, everyone's going to most likely get an H1 blocker, right? So remember that we have our common ones. Diphenhydramine is probably the go-to one in most ERs, either from an IV or PO standpoint, but other ones like chlorpheniramine or hydroxyzine can all be fine there, right? Cetirizine can be used, but if you recall, the difference between that is a second generation, so it's not going to be able to cross the blood-brain barrier. So it might be nice if you have a patient who is having a pretty minor reaction and maybe they don't want to have the sedative effects of a first generation. You may be able to get away with this. Out of the second generation, cetirizine probably kind of got the most sort of heft to it, I would think, in terms of its like clinical effects. So it tends to be sort of more effective than something like, you know, fexofenadine or loratadine or something like that. Now, H2 antagonists are going to be more kind of hit or miss whether people are going to use this. And in fact, now I got to remove this from the slide. I can't have ranitidine on there anymore because we don't use that anymore now because of the cancer risk off the market. But I could use famotidine or, you know, nizatidine or something like that instead. The idea here is if you are having an allergic reaction, you're releasing a lot of histamine, and that can then activate both H1 and H2 receptors. So by using an H2 blocker, you can maybe prevent a lot of the acid production and maybe some of the GI effects that can occur there. So not required, but you know, some patients will go ahead and get it anyway, depending on the provider. So then going up and kind of stepping up our game a little bit. So this is not, you know, if patients are having a severe enough reaction where they're showing up to the ER, they're probably going to get some corticosteroids for the most part. You know, more minor reactions, you can get oral steroids, that's going to be fine. Keep in mind though, they're always going to take time to work, right? So because they have to go down to the actual nucleus, they have to start to work on the DNA to change those transcription factors. It takes time to kick in, and so that's why I always, you know, would run into situations where in the ER you'd have a patient who's coming in with anaphylaxis, and the nurses are very, you know, ER nurses tend to be a little bit more, I'm trying to think of the word, sprightly, I guess would be the nice way to say it, but they are very much, they want to get things done right this very second, move on to the next thing. And so you know, I'd have nurses who were like, okay, you got the epinephrine, I got the Benadryl, where's the steroids? And I'm like, we're mixing it, it's going to take a little bit of time, we need it right now. It's like, it takes time to work. It's okay if it's delayed a little bit, right? Because we know these are the slowest acting ones. So from an oral standpoint, you know, prednisolone, which is the liquid formulation, you know, those are totally fine for more mild to moderate symptoms. As you're getting up to more severe cases where maybe PO is not going to be appropriate, that's where we can bust into things like our methylprednisolone, hydrocortisone, things like that are going to be the most common ones you see there. You know, a lot of patients will end up on like a 5-day course maybe just to prevent any kind of recurrent sort of secondary effects down the road, you know, maybe hours to a day later. But it just depends on the providers and kind of what they prefer. I've seen some cases where they just use dexamethasone, you know, that has a nice long half-life, so they'll say do a dose in the ER and they'll give them a dose that takes, say, 36 hours later. It just depends on the providers there, okay? And then finally, the most effective one we have, and again, it's going to be more for those severe cases, right? So you're thinking about patients who are having any kind of airway compromise, they're having hypotension at all, is where epinephrine is going to come into play, right? So most often, we're going to be giving this as an IM dose, okay? So remember, there are different concentrations out there we talked about during codes, and this is the one we're going to use the more concentrated form intramuscularly. So typically, we'll cap this out at about 0.3 milligrams as an adult dose there. So if you ever see like an EpiPen, if you look at the dose, it'll be 0.3 milligrams, whereas the EpiPen Junior for kids is like 0.15 milligrams. And so, again, there are issues with this that can occur. If you imagine causing, you know, body-wide vasoconstriction, if they have hypertension, that's a problem. Risk for MI, risk for, you know, cerebrovascular accidents and things like that. So, you know, we don't want to use it unless we really need to. And so, you know, we can use IV, and you can use it in more emergent cases there, but unless they're hypotensive, you know, there's questionable whether or not you really need to go that route. I typically try to have providers avoid sub-Q injections because the absorption can be a little more erratic in those cases there, especially if they're having a true blue reaction. So I usually stick with IM if possible. And even in some cases, we've had to require continuous infusions, kind of like what we talked about with our chronotropes and inotropes, you know, and pressors last time we talked. So, you know, it just depends on the clinical situation and kind of what's going on with that. So that's it for the ER section. Do you guys have any questions that I can answer from that standpoint? Let me get set up for the next one. Keyboard, nothing there. All right, so I will get started on the toxicology section. So obviously, I was craving a baked potato. I cannot help you with that, unfortunately. I'm not sure if the stores are out of them or not, but anyway, getting into it. So we have our toxicology section that I like to talk about quite a bit. As you know, this is kind of what I like to nerd out on most. And so the thing I want to sort of impress upon you is not how to treat every single ingestion or exposure that happens out there. I want to focus on some of the common things you're going to run into, some of the common things that happen in Florida. So this, may not be appropriate, say for instance, if you say work out in California or something like that, but we'll talk about some common things you may run into, at least while you're in the state, maybe on rotations or something. So first off, I want to talk about toxidromes, and toxidromes essentially are going to be these toxic syndromes that occur that help us to determine what type of exposure a patient's had, right? So, if I have a patient who has, say, overdosed on multiple medications and their mental status is such that they cannot communicate what they did, when they did it, there's no family around, there's no pill bottles that were, the smoking gun right next to them, and again, this doesn't have to be intentional suicide attempts. It could just be they were trying to get high, or it was an accidental overdose or something like that. A lot of times we can't get a good history, right? Or even if we have patients who are able to talk to us, especially for intentional ingestions, or if they're concerned about, legal repercussions, they frequently will not tell us the truth, right? And so they always say, how do you tell if one of your patients is lying? Well, their lips are moving, and that holds pretty true, unfortunately, in a lot of cases here. So essentially what I have to do is kind of work as like a detective. So this is where I got kind of most of my sort of diagnostic sort of mindset, because what you guys would do for a patient coming with belly pain, as a toxicologist, I get to do for patients coming in for drug exposures, right? Or any kind of exposure. It could be biological warfare, it could be really anything. And so by looking at their signs and symptoms, I come up with an idea of like, these are the things that are most consistent, here are the things that are not, and try to come up with a treatment plan based off of that. Because unfortunately, you're going to find that a lot of drugs do not have antidotes, unfortunately. And most of the time, it just takes time. But we can help with determining what are the appropriate supportive measures, what can we do in terms of, further testing and things like that. So that's kind of where I come into play, is in terms of being a toxicologist and when I'm acting as a consultant with providers out there, in the state of Florida. So anyway, if you ever heard the term toxin versus toxicant, that is one thing that you'll probably hear me mix up all the time. But toxin is really anything that comes from a natural source. So things like botulinum toxin or like snake venom is a toxin, versus toxicant it is really anything else. So like all pharmaceuticals and whatnot tend to be considered toxicants because they come from like a non-natural sort of source there. Like so lead poisoning would be considered something like a toxicant, right? So some of the toxidromes I'd like to cover, these are kind of the most common things that you will find sort of coming in terms of drug exposure. So we have our cholinergic, our anticholinergic, things that are considered to be sedative, hypnotic, opiate, sympathomimetic, and then some withdrawal syndrome. So these are the things I kind of want you to cover, and things I might ask about on the test. I might say a patient comes in presenting like this, and your job would be able to identify, okay, what do I think is most likely to be causing this, and maybe what sort of treatment is that patient going to require, right? So obviously if I'm describing something like an opiate overdose, you'd know to try naloxone, right, for instance. So anyway, so getting into the cholinergic poisoning first. So basically this most frequently is going to occur due to inhibition of cholinesterase. And we looked at some drugs that do that already. Things like, neostigmine, we talked about during the surgery section a little bit, or actually with our paralytics we talked about. And again, you're going to expect to see increases in both nicotinic and muscarinic activation, because as you have increasing levels of acetylcholine, it doesn't really know what receptor is really hitting there. The other big places you're going to see a lot of cholinergic poisoning actually comes from organophosphates. And so that includes a lot of insecticides, things like malathion and parathion, that basically they're going to have a much different sort of mechanism, as we're going to see in a little bit, in terms of like duration of action and things like that. And so we're going to look at how these work. And again, a lot of these insecticides we don't use a lot here in the US, but in a lot of developing countries or places that may be a little bit more poor, you're going to find that these insecticides are still used because they are so effective. They're cheap. Their safety profile is not great, though. And so we've kind of gotten away from a lot of those here, but you can see in certain places in the world that they still use a ton. And so this may be important if you were to, say, practice abroad, perhaps. In terms of other things that may be a little bit more specific, so certainly nicotine, as you might imagine, is not going to be working on muscarinic receptors, but work specifically on nicotinic receptors, right? And so they can have a different sort of skew in terms of how patients may be presenting. And then there's always things like sarin, soman, and tabin, which are nerve agents. And so actually these were in the news a couple of years ago, I believe over in the Middle East. There, I can't remember the country off the top of my head, unfortunately, but there was some bad actors who were using some of these nerve agents on the people that were living there, unfortunately. So we'll look at some of the different ways that this actually occurs. And typically when you're looking at the enzyme acetylcholinesterase, you can see how normally it will bind to acetylcholine and then normally cleave it here into both acetic acid and choline. Choline then gets recycled back into the presynaptic nerve where it can be recycled back into acetylcholine. Well, what would happen here is if I inhibited this enzyme, you'd end up seeing you're going to have way too much acetylcholine out here activating all of those receptors, right? And so that's essentially what happens. Imagine you have an organophosphate, right? So this is what the typical structure might look like, binding to acetylcholinesterase, and basically it causes this covalent bond to eventually occur. And so once this happens, no longer can the acetylcholinesterase actually go and work on acetylcholine. So what ends up happening is that basically it's this competitive inhibition initially, but a lot of these agents, especially the non-reversible ones, undergo this covalent bonding, and at that point, once the acetylcholinesterase enzyme is covalently bonded, it's done. Like, you can't do anything anymore, and you have to wait for the body to actually come up with a new enzyme itself. And so a lot of the organophosphates tend to be irreversible, and it's a process we call it aging, where that covalent bond occurs. And depending on the agent, it can be minutes to hours. So a lot of those insecticides I mentioned, you may have hours to deal with it before the patients have that aging process happen. Versus something like some of the nerve agents I mentioned, like sarin gas and things like that, can happen within minutes potentially. So it can be a really big difference in terms of what kind of exposure you see. A lot of the carbamates, things like physostigmine, pyridostigmine, neostigmine, they are all going to be reversible. So it's going to be a case where the effects are going to be limited, and once the drug gets metabolized, then the system goes back to normal. So if you're using something like, say, you had a patient who's in surgery, they receive, say, rocuronium during the surgery, and you want to reverse that, using a carbamate is a good idea because it will help to get that acetylcholine levels up, kick that paralytic off the receptor, and then you have normal function again. But then the carbamate will get metabolized off, and then it's gone, right? So then things go back to normal essentially. So the old way we used to do the muscarinic effects, I know I've talked about these before, so this will just be retreading old material. We used to call it sludge, but the reason why we kind of changed over from this is because we wanted to include the killer bees, is what we call it. So things like bradycardia, bronchorrhea, and bronchospasm. That's typically how these patients will end up dying if things are not appropriate measures are not taken beforehand. I mean, no one's really going to pee themselves to death, right, for the most part. But if your lungs fill up with fluid and you're having bronchospasm, then you're not going to be able to oxygenate very well, and that can be fatal, right? So again, defecation, urination, meiosis, bradycardia, bronchorrhea, bronchospasm, and then your emesis, lacrimation, and salivation. That's the dumbbells. That's how we remember this toxidrome. So if I ask you on a test question, I say, oh, a patient had a history of exposure to, he works on a farm, and then he's coming in and he's incontinent of urine and stool, and he's sounds junky on the lungs. Like, you should be able to pick out that sounds like a cholinergic toxidrome, right? Based off of all these things here on the dumbbells, right? So that's kind of the process I want you to start thinking through when you end up seeing these kind of cases potentially. From the nicotinic side of things, I like to remember this with the days of the week. So before the last slide were all the cholinergic effects, the muscarinic effects, I should say. Now we're getting to the nicotinic effects. Again, you can see me not being always precise in my language, but so the nicotinic effects, the days of the week, I do mydriasis, which again is different than the meiosis you saw on the last slide, right? So initially these patients may be presenting with nicotinic effects, and then progress into the cholinergic or the muscarinic effects there. Or imagine if you had a patient who had overdosed on nicotine, right? So this is a big concern we had with patients when like e-cigarettes and vaping pens and stuff like that were initially coming out. There was not a lot of regulation on the refill liquids you could get for this nicotine, and it was really, really strong, potent stuff, and kids would get into it and have very severe nicotinic effects, right? So you see that mydriasis, you can see tachycardia as a result of nicotinic stimulation on actually on the sympathetic effects, right? So if you go back and you look at your diagrams of how the sympathetic nervous system is designed, you'll see that there's some pre-ganglionic nerves that are releasing acetylcholine onto nicotinic receptors. That's how you can get that stimulation there. That's how you can get that tachycardia, as opposed to the muscarinic effects you see later on due to the acetylcholine affecting those muscarinic receptors, right? The other big thing you're going to see is that just like with succinylcholine being a depolarizing neuromuscular blocker, having too much acetylcholine can do the same thing. So you can end up seeing fasciculations, which is the Friday here, leading to weakness. You can see eventually paralysis actually can occur. And this is another reason why these patients may have respiratory failure, is due to diaphragmatic paralysis on top of some of the muscarinic effects of having all that bronchorrhea and bronchospasm. So you can see that from an oxygenation standpoint, this can be a big issue for these patients. The other thing you're going to see is hypertension typically. And again, notice how these patients may differ. If it was just a purely nicotinic exposure, you would not get any of those muscarinic effects, as opposed to if it was, say, an agent that affected acetylcholinesterase, entirely having both muscarinic and nicotinic effects. So there's some differences there. So in addition to that, there's going to be some CNS effects we can expect to see, so things like slurred speech and ataxia, all the way up through psychosis, hallucination, seizure can all happen here as well with these cholinergic effects. So how do you treat that, right? So basically one of the big things you want to do is always ABCs, right? So make sure you're taking care of the airway, breathing, and circulation. The airway and breathing will probably be one of the bigger concerns here, depending on kind of when they're presenting. Not only that, but we also have to worry about things like hydrocarbons that these organophosphates and things have actually been suspended in. And so the issue there is that hydrocarbons, when they get aspirated potentially, because we know that emesis is going to be a component of this toxidrome, that can cause respiratory distress syndrome. That can cause a chemical pneumonitis, which is the issue there. So consider that. Typically in terms of decontamination, which I'm going to talk more about later on, a lot of these organophosphates and insecticides can actually be absorbed through the skin. So it may not just be that they drank it, but what if they got a dermal exposure to it? Anytime you're dealing with any kind of lipid-soluble compounds, you can't just use water to wash it away. And I'll get into this a little later, but anytime you're not sure, make sure you're using soap and water, right? Using a basic product like a soap will be able to help get rid of those lipid-soluble products more easily, right? Just like we talked about using like capsaicin and using like olive oil or milk or something like that to get rid of the capsaicin because of the lipid solubility of the compound, right? In terms of antidotal therapy, some things we can do there. So if they're having a lot of muscarinic effects, so they're having the dumbbells, atropine is a drug of choice for that, right? You're going to be able to basically block those muscarinic receptors and reverse those effects there. Okay, so that's the main treatment for the muscarinic effects. There's not a whole lot we can do for the nicotinic effects, unfortunately. But there's another drug here called pralidoxime or 2-PAM, and this is like really the saving antidotal agent if you have something that is going to have an irreversible effect. So if you had exposure to something like sarin gas, or you had exposure to an organophosphate, this is the really important one for them to be on. And basically what it does is it prevents the aging from occurring. It basically saves that acetylcholinesterase and allows it to start to function again, essentially. So that's a really important one. It's frequently called 2-PAM. You may hear that term being used for pralidoxime. And so this is really the antidotal agent. In terms of seizures, one of the big things you're going to note here is that typical seizure management with things like phenytoin or like valproic acid is not going to really be effective here for toxin-induced seizures. And so typically our first choice is always going to be benzos. So you do benzo. If that does not work, and then we can start to consider some backup agents. So using barbiturates, things like thiopental or phenobarb, and then if that's still not working, maybe even going to something like propofol. Propofol itself does have some anti-seizure properties, and so that can be a useful second or third line agent for those patients there, right? Again, the atropine itself is really to help out with those excess pulmonary secretions to make sure you're trying to dry them out. And some patients have even need to have, be placed on an atropine drip in some cases there. The goal is really to make sure the lungs sound clear. I've had some patients or some providers that will stop giving it once the patient becomes tachycardic. I don't really care. I'm not so worried about their tachycardia. It's really the lungs that we want to have good oxygenation occurring in. So that's the big thing there. And again, don't get too hung up on the dosing. I'm not going to ask you specific dosing on the test, but I may ask you what are the specific agents you'd want to give given a potential exposure, right? And I'll make it pretty clear in terms of what we're looking for. And so again, pralidoxime, we'll typically put them on a maintenance infusion, and then once they stop requiring atropine for those effects, then we can go ahead and try to wean them off the pralidoxime to see how they do. Assuming they don't have recurrence of symptoms, and they're usually good to go at that point. Usually the product is already gone. So then getting into the anticholinergic, this is probably way more common as something you're going to end up seeing in terms of clinical presentations. This is mainly due to the fact that there's going to be so many more medications potentially that are going to be causing this anticholinergic toxidrome, right? So we've covered a lot of them already, including our antihistamines, like a lot of cough and cold preparations. We know a lot of our antidepressants, things like TCAs can cause this. A lot of antipsychotics can cause this. But not only that, but you have to also consider the a lot of plant exposures that can occur here, right? So, you know, some of this may be accidental, like kids getting into plants out in the backyard or something. I know that my 2-year-old cannot, for whatever reason, she just loves eating plants and little flowers. And so fortunately, our garden is set up to where we have no poisonous ones, and she just munches away for whatever reason. So anyway, I promise we're not terrible parents, but actually maybe they'll have to tell us in 16 years or so. But we also have things like the belladonna alkaloids, right? So this includes things like hyoscyamine, this includes things like scopolamine and things that are found in a lot of these plants, things like angel's trumpet and Jimson weed, which are two things that actually here do grow in Florida. And so does anyone know where the term belladonna alkaloids actually comes from? I probably mentioned it to you before, but if you want to throw that in the chat, it'll be a good little trivia thing. So anyway, so these are the common agents you're going to see causing this anticholinergic toxidrome. So getting into the effects here, we're going to expect to see anti-muscarinic effects. You really don't get anti-nicotinic effects from this, but certainly we know if we did have anti-nicotinic effects, that would be like your paralytics we've looked at before. And basically these agents are just working as a competitive antagonist for those muscarinic receptors. And of course, we know the mnemonic. We've probably talked about this or have drilled it into you over the past year or so. But just to reiterate again, it's the red as a beet, dry as a bone, mad as a hatter. If you're finding people who are using these for abuse purposes, this is typically what they're going for. Again, early doses, low doses, you can see CNS depression all the way up to you know, euphoric kind of feelings, hallucinations, all the way to severe psychosis, all the way up to seizures. And seizures can be really difficult to treat in these patients here. You'll get them to have these, they'll come in, they'll have these big saucer-looking pupils, very mydriatic, and then they get typically pretty hyperthermic as well. They can be up to like, you know, 103, 104 in some cases, depending on the exposure and things like that, you know. So the cardiovascular effects are also really important. You tend to see mostly tachycardia as being the most common thing, maybe a little hypotension associated with that. And then another big concern is actually going to be the gastrointestinal effects. So one of the things you'll see with anti-muscarinic activity here is you slow down bowel motility. So the GI tract can be slowed down, and that can actually be clinically important because if the patient still has a lot of drug sitting there in their stomach, they may not have absorbed it yet due to this decreased motility. And then as the patient starts to work off some of that drug and start to improve, then you will find that the GI tract wakes up, and then they may reabsorb that drug, and then now all of a sudden they're you know, kind of sliding back down the clinical spectrum there, so to speak. So that's one thing you want to be careful of, and we always make sure we're listening to bowel sounds for these patients here. Let's see, Brittany says, bloated as a toad, the heart runs alone. Yes, I've heard that the heart runs alone. I've never heard bloated as a toad, but that makes sense in terms of the decreased GI motility and urinary retention. So that's a good one. And then in terms of CNS, again, the seizures I mentioned can be pretty problematic. So the reason why this is tough is because there's so many medications that can present with an anticholinergic toxidrome. It's also really difficult to determine, is a patient really anticholinergic? Are they having some of these other sort of toxidromes that may look sort of similar, right? So here's just some things that could look very similar to anticholinergic toxidrome, things like Symphyromimetics, like cocaine or amphetamines, a lot of withdrawal syndromes, right? So if you're withdrawing from a sedative agent or an opioid, even things like serotonin syndrome and neuroleptic malignant syndrome can all do this. Then salicylate poisoning, sepsis, if they're having thyroid storm, you know, adrenergic access, all of that could look very similar. And so it's really difficult to determine in some cases. And so you have to look at the history, right? Look at the drug exposure, look at, you know, things like E-Force to help you out in some cases, or look at maybe some other things like, you know, okay, you know, do they have an infectious source? You know, what's their white count doing? These are all things you can look at. So in terms of treatment, we'll talk about the GI decontamination just a little bit, but the main thing for these patients is mostly supportive care. Oftentimes these patients are very agitated, and if they're having seizures, obviously we mentioned the benzos are going to be our drug of choice here. I'll give you an example of just how severe the agitation can be in these patients here. And I remember we had one patient who came in, there was a party that was going on. We ended up getting like 2 or 3 patients all at the same ER. And this one guy, though, he had done a drug called Corseed cough and cold, and the name for it is triple C. And the reason why you see a lot of teenage abuse of anticholinergics is because of the fact that it's readily available, right? You can go and buy a whole bunch of antihistamines. I can buy a bunch of Benadryl right now in order to get high, right? I would not recommend anyone do that, but this is what these patients did. So at a party, and basically this drug came in as basically a blister pack. So you may have like 15, 20 pills in a single plate, they called it, and then they would either do between 1 and 3 plates. So problem was, this one guy, he had never done the drug before, and so he ended up thinking, obviously teenage males tend to have more testosterone than they do sense, and so he's going for the gusto, and he ended up doing 2 plates when he probably should not have done any, or started at 1 at the very least. So anyways, we got severely agitated, possible seizure-like activity. They called EMS, came and picked him up, brought him in, right? Cops busted up the party, all of that. So anyways, this guy's coming in, and, if you have a patient who's seizing, typically like 2 milligrams of Ativan is enough to stop most seizures for a lot of patients. This guy ended up getting 14 milligrams before he went to sleep. He was so agitated, wouldn't stop, fighting with nurses, and they were trying to put IVs in him, and he just wouldn't let them, and all these things, right? So 14 milligrams to get him to go to sleep, and he's still kind of jittering around, versus 2 milligrams for a typical seizure. So this is very, very potent stuff here you're dealing with, so you want to be very cautious with it. In terms of their tachycardia, again, fluids can help out with this, just to make sure they're intravascularly repleted, and then benzos can sometimes help out as well. Now, the antidote is a drug called physostigmine. Physostigmine, if we know the problem is the fact we don't have enough acetylcholine around to occupy these receptors, we can give physostigmine, and this is a reversible acetylcholinesterase inhibitor, right? So basically something like neostigmine, we can give physostigmine, and it works very well to help kind of reverse this. It's not given too frequently. Most patients can just kind of receive supportive care, and with time will go in on its own, but physostigmine is the possible antidote you may give for this. Again, as mentioned, it's a reversible thing. It actually comes from a plant source, this Physostigma venosum. Again, I'm not going to ask you plant sources on the test, but just for your knowledge. And again, we have to be really cautious when we're giving this, mainly because if you push it too fast, you can see kind of the reverse effects, and you end up getting too much acetylcholine activity, and so you can see things like bradycardia potentially, but it will have effects on both nicotinic, muscarinic, and everything, because it's acetylcholinesterase inhibitor, just like we were looking at before. So typically we get this if they're having like refractory seizures, or they're having severe psychosis that's not being managed with benzos, or maybe if they're having say like an arrhythmia, tachyarrhythmia, we need to treat, that we can sometimes use that. And we don't like to use this for a lot of cases, mainly because in some patients the cholinergic excess may be too problematic. So if they have like asthma or COPD, that could induce an attack there. TCA ingestions, there's been some negative effects. So because of the contraindications, a lot of providers don't like to use it, but I've seen some decent use of it, especially for like a plant ingestion or something like that. So anyway, again, don't give it too quickly, because you see those cholinergic symptoms, which can lead to things like hypersalivation, bradycardia, things like that. And it takes a few minutes for it to really kick in. So up next, then, we can get into our sympathomimetic toxidrome. And again, I mentioned this looks a lot like the anti-muscarinic toxidrome. We'll talk about some key differences here. And in fact, you can actually find that depending on the agent, you may have different kind of flavors of that sympathomimetic toxidrome. So for instance, things like alpha agonists that work primarily in causing vasoconstriction are going to appear different in terms of their effects than something like a beta agonist versus something that has kind of mixed activity. And you'll notice the mixed activity group is kind of the one that has the most options in there, between things like pseudoephedrine, which you can get from the pharmacy, all the way up to amphetamines and PCP, LSD, and all that kind of fun stuff, right? I don't know if anyone's ever heard of clenbuterol before, but that's kind of an interesting one that I've seen a few case reports where it's a drug used in certain like bodybuilding and fitness communities because it's thought to activate beta-3 receptors and actually cause lipolysis and help with fat loss. And there was a case where there was like 2 bodybuilders that had basically, they cooked their own clenbuterol in their kitchen or somewhere, and they ended up taking a bunch of it, not realizing how much they were really dealing with. They actually ended up developing like severe hypokalemia, to kind of follow up on what we were talking about last lecture set. So clenbuterol, they came in like potassium's like, I think in like 2.5, something like that. So it was, actually I think it was even lower than that. It was very low potassium levels that were being temporarily kind of shuttled into the cell until the clenbuterol kind of got off the system, essentially. But anyway, so some things we're going to see here in terms of the pharmacology, the sympathomimetics, depending on the agent, they work a little differently. So for instance, you can have agents that directly work at the receptors, right? So you can have things like epinephrine that directly activate alpha and beta receptors like we saw last time, right? In some cases, you can have drugs that will cause the release of catecholamines from the CNS. So things like cocaine and amphetamines can directly release things like norepi, causing their sympathomimetic effects, so again, mimicking the sympathetic nervous system. This is also where you get a lot of that dopamine release, and that's why we see these drugs being addictive, is because they cause a lot of dopamine release. They kind of flood that reward pathway, and there you go. And then in other cases, you may find that it's related to like blocking reuptake of catecholamines, things like MAOIs, and maybe TCAs to some small amount can present sort of similar to this. So things we'd expect to see in terms of clinical effects from a alpha stimulation effect, things you're looking for include things like mydriasis. You can see arterial vasoconstriction, so you expect to see hypertension, think a diaphoretic. Even in some cases, you worry about things like platelet aggregation. And so, for instance, you may potentially even induce MI in some patients due to the combination of vasoconstriction, plus you're activating all these platelets, and thus you can end up seeing MIs, right? So we talk a lot about, especially if you work in areas with a large amount of cocaine use or like crack cocaine use, a lot of patients are coming in for crack chest pain. And so you have to do a cardiac workout on them, basically, because they're having all this cocaine coming in and causing vasoconstriction. Maybe they have a history of angina, and then I got to work them up for that, right? So again, a lot of it could be related to this alpha stimulation. With beta-1 stimulation, again, we know that's primarily on the heart, so you're expecting to see increased inotropy, increased chronotropy, right? This can include tachyarrhythmias, but most often sinus tach is going to be the most common thing you're going to find them coming in with. And then for the beta-2 effects, you're going to expect to see some smooth muscle relaxation. So again, you can use it as like a bronchodilator. You expect to see hypokalemia and even some arterial vasodilation. So in some cases, there's kind of a balance between the alpha effects and the beta-2 effects, kind of balancing each other out so that way they don't get too hypertensive in some situations. So, and again, depending on how they're presenting, you can see that they can present very differently, right? So if I have a pure alpha agonist, then maybe they're coming in hypertensive with maybe a normal or even maybe a slightly decreased heart rate, versus say something like a beta-2 agonist, they're coming in tachycardic, but they're hypotensive. Or maybe if they're mixed, then you can end up coming in with any kind of combination of these. So again, just don't expect everyone to be hypertensive tachycardic. It'll be with a lot of cases with things like amphetamines and whatnot, but not every drug will present that same way, okay? And so, as I mentioned, it's difficult to discern the difference here between anticholinergics and pathomimetics and a lot of these other things. Some things you will look for, though, include, for instance, if you had to imagine someone who had done a whole bunch of cocaine versus someone who had done, say, for instance, a whole bunch of Benadryl, right? Well, I would expect someone like cocaine to be very diaphoretic and they're hyperthermic. The person who took the anticholinergic, though, should be relatively dry, right? Because, again, we know that's going to be holding on to or decreasing fluid secretion, including no sweating. That could be one thing, right? Versus, say, for instance, you listen to the bowel sounds. Someone who's done a whole bunch of cocaine probably will have active bowel sounds because, again, you're stimulating motility there. You could see diarrhea maybe. Versus anticholinergic, it should sound decreased to absent potentially, right? So there are little things we can look for to try to differentiate between the different substances these patients might be exposed to, right? So again, this is another slide just kind of showing you the differences or how they show so very similar versus here you can find, oops, if I can get to the actual slide I want. You can find here how the differences, right? So again, they look very similar for the most part down until you can get down to like the mucous membranes and the actual intestinal motility. So how do we manage these patients here? Well, again, ABCs, and we'll talk about GI decontamination. This is the case where you may actually find, especially if you work in places like international airports, or if you work down in, say, like Miami-Dade, for instance, we do worry about drug mules, or basically not actual mules themselves, because this is not veterinary medicine, but patients who have maybe taken large amounts of medications that have been pretty well wrapped, and in order to move them across country lines and things like that. And so that has been one case there where certain routes of GI decontamination can be really important, which we'll talk about a little bit later. The ideal thing is to try to calm the patient down, put them in a cool environment if possible. In some cases, they require active cooling. So if they come in, say for instance, they have an amphetamine exposure and their temperature is like 104, 105, you might do things like evaporative cooling, where you try to spritz them down with water and you put a fan on them, or you put ice packs on them, or using cooled IV fluids or something like that. These things can all be useful here. For the most part, though, the kind of drug of choice is going to be your benzos, though, right? So it can help out with the hypertension. It can help out with tachycardia, agitation, etc. So those are the big things there. In terms of like, if you still need to treat the hypertension or tachycardia, you don't want to be cautious here, and you can use things like maybe short-acting beta blockers, things like nitroprusside. So be cautious there. For the most part, benzos are going to be kind of your best friend when managing these kind of patients here. So then up next we have our opioid toxidrome, and so we know a lot about the opioids already. We've talked about them quite a bit. Again, they come from the poppy plant, or the Papaver somniferum, and this is where we get a lot of our things like morphine, heroin, and codeine, and things like that. When we talk about opioids versus opiates, opiates are typically like the naturally occurring alkaloids, whereas opioids tend to refer to kind of all the other stuff. So things that maybe not be structurally alike, but have the same effects, like things like fentanyl and tramadol and whatnot are considered opioids. And again, you'll probably hear me use the two terms interchangeably, so a little bit of nomenclature there. I don't know if you guys knew this, but I used to have a heroin addiction myself. I really just couldn't get enough of women who save people's lives, but fortunately I was able to kick that habit, so things are much better now. But getting into the pharmacology, we see here that we have our mu, kappa, and delta receptors. Basically, the mu is the main one of clinical importance I'm going to care about, and I'm going to talk about mostly here. This is where you get the analgesia. This is where you get respiratory depression, the really dangerous stuff, euphoria, which most people are trying to abuse this for. Different agents may have differing activities at kappa and delta, and I'm not really going to mention these too much, but they can have kind of varying effects. But if you're ever really interested, you can dive deeper into that. But for the most part, let's just focus on the mu receptors. And so there can be a lot of different routes of exposure here. So for instance, I mean, people can snort, OxyContin. People can abuse fentanyl patches. I'm sorry you choked on your water, Brittany. Glad you thought it was funny. Most people probably didn't, so there's that. Anyway, so when you're looking at it, though, remember maximal time of effect can vary on the route, right? So typically, if you're considering like an oral dosage form, probably going to be a lot slower than something like an IV or an inhaled form. Inhaled tends to be some of the fastest onset of action, whether you're dealing with inhaled cocaine, inhaled, if you're trying to smoke a fentanyl patch or something like that, mainly because it gets absorbed through the lungs, gets back to the heart, and right to the brain. So it's a very, very fast onset there. The other big thing you have to worry about with opioids is the fact that the duration of action can be wildly different, right? Which means that the thing I have to worry about is like how long may they have recurrent symptoms, right? So a typical morphine overdose, say it's a morphine IR, 1.5 to 3 hours maybe you're getting maximal effect, versus methadone could be up to like 15, 30 hours. Or it feels like morphine extended release, and I'm all of a sudden thinking longer time frames. So a lot of that can be pretty variable, especially when we're talking about our antidotal therapy here. The biggest thing you're going to expect to see with their clinical presentation is going to be CNS and respiratory depression, right? Basically, the opioids are going to kind of turn off your brainstem's response to increased levels of CO2. And so that can be a really useful monitoring parameter to actually look at their end-tidal CO2 if you have that capability there. But CNS depression, most common. You can see meiosis, and a lot of people talk about having pinpoint pupils. I'll tell you, not everyone gets that, and so actually some agents like tramadol frequently don't cause that. They can actually cause mydriasis. But that trifecta, that triad of opioid effects is CNS, respiratory depression, and meiosis. So it's kind of, if you ever hear that on rotations or something, that's what they're looking for. In terms of cardiovascular effects, you don't really find a whole lot. In terms of GI effects, so you will see some slowing down. Just like with the anticholinergics, you're going to slow down motility, and that can lead to decreased or delayed absorption of drug, as that can be an issue in some cases there. So not only that, but you may have some of the agents that can cause things like seizures, or, for instance, things like meperidine or tramadol. Some of them can have serotonin effects, so that can be a problem if they're on other serotonergic drugs like antidepressants, for instance. And then we also have to worry about things like buprenorphine being a partial agonist. And if you recall, normally buprenorphine is being used to help patients wean them off from opioid addictions and opioid dependence. And in some cases, if patients are switching from, say, methadone, which is a full agonist, and they end up abusing buprenorphine, that can actually put them into withdrawal, right? So it may look totally different than what we'd expect coming through the EMS doors, right? So anyway, when you're looking at drug screens, and drug screen can be sometimes useful, a lot of times they are not, right? And so this is going to be kind of broadly applied to most other things. Know what you're testing for in a lot of cases. And so when most patients come in for an accidental exposure or some kind of drug exposure, the first thing that people want to order is a urine drug screen, right? And so again, this is going to be one of those things where I ask, you know, if a test, the results of which are not going to change your management whatsoever, what's the point of ordering it? And frequently urine drug screens have no effects on what you're going to be, will have no change in your management, right? So most routine drug screens, or say for instance something you would take like prior to getting a job, really only test for a couple of different agents. And so, you know, things like marijuana's on there, which is specifically looking for THC, you know, benzos, certain opioids, but you have to wonder what these are actually detecting. So for instance, a lot of those routine drug screens, they'll pick up things like heroin and morphine and hydrocodone because they look pretty similar to the original compound that comes from the poppy plant. It doesn't detect a lot of things that are maybe more synthetic looking, or things that are that just don't share that same structure, right? So things like tramadol and fentanyl routinely don't show up unless you are specifically testing for them. So wherever you go to work, especially if you maybe work in the emergency department, get a feel for and talk to your lab people in terms of like what these tests actually detect and what they don't. Another big issue I run into frequently is false positives and false negatives. So for instance, if someone's using pseudoephedrine, it will show up as an amphetamine, right? And of course, you know, you can make amphetamines from pseudoephedrine, which is why they're behind the pharmacy counter. But these are things that are you have to consider, right? Even patients who have Parkinson's or on selegiline, that can show up positive for amphetamines, and you know, so little things like that. So not to get too much on the soapbox, but just be cautious when you're testing for these things. Because ultimately, the best way I can tell from having an actual opioid exposure is just to give them some naloxone, right? So we talked about naloxone before being that competitive opioid receptor antagonist, basically kicking all that off of there. And you can give this very varying ways. Intranasal is becoming very popular for out-of-hospital use, especially if you have like police officers who are responding to a call. But IM, IV, I've even seen some cases where they're trying to use it via nebulizer. Where basically patients who are, still, not to the point of needing to be intubated by any means, but were pretty CNS depressed, they'd actually put the naloxone to a nebulizer. They can kind of breathe it in, and as they started to get the effects of it, and they started to have minor withdrawal syndromes, the patient kind of wake up enough, they pull it off, and then as they resedate it, they put it back on eventually. So anyway, the important thing to note about naloxone is that within 20 to 30 minutes or so, the majority of the effects are going to go away. And so again, this is another really big important point to mention for, say, out of hospital management, or say if you're giving this to a caretaker or a loved one for a patient who might be at risk for opioid overdose, is to let them know that you got to call 911 after you administer the naloxone, because by 20 or 30 minutes it's going to start to wear off and that patient may resedate. And this is a big concern here in the ER and in the hospital in general, because say you have someone who overdosed on methadone, and maybe the GI tract's starting to slow down, they have a whole belly full of it too, that you may not be able to get with GI decontamination. You're going to find that patients may resedate for hours and hours after the ingestion. So in some cases we actually have to use naloxone drips in order to keep them at a point where they're still breathing. They don't have to be awake, but they want them to at least be breathing and getting off that CO2. I'm not going to ask you specific dosing, but just know that especially with the synthetic ones, like things like buprenorphine and tramadol, you may need really high doses in order to get them to have that to get the effect of the naloxone. So, typical doses like 2 milligrams for a patient. Say like a heroin overdose, they're definitely going to wake up if that's what's the only thing causing their CNS depression. But you may need to like 10 milligrams before you can really say, no, this patient probably doesn't have an opioid on board. And then we can use our maintenance drip if we need to in order to help keep them at an adequate level of arousal. And basically we just want them to be able to arouse to voice. We don't need them to be fully awake, but as long as they can wake up to voice, that's usually good enough for us. And so, again, the biggest thing is just opioid withdrawal being the issue there. So, your nurses are not going to like you, the patient's not going to like you, so don't give too much in these cases here. Let's see, how many breaths per minute does a patient have to fall below in naloxone to be indicated? Or let me see, part of my chat boxes. In order for naloxone to be indicated? That's a good question, and there's actually not there's not a good number to tell you for that. A lot of it has to do with the fact that it may not just be bradypnea that they're experiencing, but it could be they have just very shallow breaths, right? So their tidal volume may not really be sufficient in order to cause a good enough gas exchange, which is why I really like it if we can do things like in-tidal CO2 monitoring, right? So if they're sitting there at, say, 50 or 60 on their in-tidal CO2, they're not oxygenating well, even though they may be breathing, 12, 14 times a minute. So that may be a better indicator to go with. But frequently, if a patient is not rousable to voice or, painful stimulation and they appear to be, breathing maybe 8-10 times a minute or something like that, that whole clinical picture looks severe enough that maybe you want to go ahead and give them the naloxone. In some cases, it may be a diagnostic, right? So it could be, I want to know, is this patient sedate because they have an opioid on board, or is it something else, right? I can give them naloxone if they wake up like The Exorcist, and then I know that, yeah, this is definitely what's causing the issue here. Okay. Again, and that opioid withdrawal will be short-lived as long as the drug is still sitting around 20 or 30 minutes, so it should start to kind of dissipate over time. Okay, that's a good question. I wish there's a better answer to that one specifically, but that's always been a bit of a challenge, because some patients will have a normal respiratory rate and they say, okay, well, they're good to go, and then they're still holding on to a lot of CO2 that, before we had reliable in-tidal CO2 monitoring at the bedside, we'd have to wait for ABGs or something to come back to tell us. Okay, and then getting into our sedative hypnotics. So these are basically going to be a pretty wide range of substances here. So this includes things like your benzodiazepines, your barbiturates, muscle relaxants, and miscellaneous agents, things like ethanol, GHB, which was a popular date rape drug back in the day, chlorohydrate, or if you ever heard of like slipping someone a Mickey, which I think I've probably told you about before. These are all kind of fitting into the same sort of sedative hypnotic sort of category. Butalbital or Fiorset, this is probably the most common barbiturate you're going to have people come in on. This is frequently used for migraines, even though it's probably not all that effective. Typically, Fiorset either has a combination of butalbital, caffeine, and then Fiorset has acetaminophen in it, and Fiorinol has aspirin in it. But butalbital does actually show up on a urine drug screen as a barbiturate. So this is not a popular group of drugs for patients to abuse. So whenever it comes up on a urine drug screen and providers are like, okay, it must be a barbiturate overdose, I'll go and try to talk to the patient and say, hey, do you have migraines? They'll say, yeah. And I say, do you take Fiorset for it? They go, oh, yeah, I take Fiorset. That's usually what the issue is. So how most of these are going to be working is going to be at the GABA receptor itself. GABA A is predominantly the biggest thing we're going to be focusing on. And again, by allowing them to open that GABA channel more frequently, you're going to have more chloride flowing in and then hyperpolarizing the cell, right? So that's why you see so much of that sedation. For the most part, not as much respiratory depression as an opioid, but maybe you can get that, especially if you start to mix and match these agents together. So if you put alcohol and benzos together, you're going to see potentially some respiratory depression because they do work synergistically. So again, CNS depression is going to be the most common thing you're going to run into. How respiratory depressed they get may be dependent on the ingestion itself. Normally, if you see anything from a cardiovascular standpoint, you'll see maybe some mild hypotension, which may be a little worse with certain classes, things like the barbiturates. You may see some decreased GI motility potentially, and also consider that some of them may have anticholinergic properties as well, which does cloud the clinical picture. And so you can see things like carisoprodol or soma or like cyclobenzaprine can have that. And I'll tell you that the most common drug combination you'll see coming in, either due to accidental or intentional overdoses for like abuse purposes, is going to be an opioid. It's going to be a muscle relaxant, and it's going to be benzo. So as time goes on, I hope we get better at not prescribing that triad of drugs. But it's so common to see patients coming in, found out passed out on the side of the road, or found down in the home or something like that, and they're invariably on that three combinations of muscle relaxant, benzo, and opioid. And again, they're really can be potentially deadly when used in combination like that. So anyway, so how we're going to manage these patients here is mainly going to be airway management. So if you need to intubate, and then help with the hypotension with fluids and maybe pressures if you need to, like we talked about before. The only antidote we have here is for benzos only. So there's no antidote for barbiturates, there's no antidote for muscle relaxants, but we do have flumazenil for the benzos. Keep in mind, though, that benzo withdrawal can be a lot worse than any other type of withdrawal, mainly because of the fact you can have withdrawal seizures, right? The body's used to having all that GABA around, and then all of a sudden you get rid of that GABA effect from the benzos. Too much glutamate activity is going to cause a seizure, right? And so for the most part, I find that most patients, unless it's like a kid getting into a barbiturate, or sorry, for a benzo for the first time, or maybe it's like after surgery and the patients are not chronically on benzos, you want to wake them up a little faster. That's the only place I really see a lot of flumazenil being used. Other than that, we can support the patient through the ingestion until the drug wears off, as opposed to the flumazenil and giving that. Because if you induce a seizure in those patients, guess what you got to do to treat the patient? Well, you got to give them more benzos, right? So it can be kind of shooting yourself in the foot there. In terms of enhanced elimination, we don't have a lot of options here. I'm not really going to get into the specifics about things like urinary alkalization and multi-dose charcoal. We'll talk about charcoal later. But essentially, there's some ways you can help to clear a drug faster by giving bicarb, and that actually helps to alkalize the urine to a higher pH. You can clear drugs a little faster. So I use that a lot for aspirin overdoses, but you can use it for phenobarb too. In terms of withdrawal, again, a lot of these withdrawal syndromes can look similar to, say, like a sedative, like a sympathomimetic, right? So if you're withdrawing from a sedative hypnotic, you can get anxious, you can get agitated, you can have tachycardia and hypertension. The biggest things, though, is just with opioids, no withdrawal seizures. So very rarely, if ever, fatal sedative hypnotics. Absolutely, you can see that. So if they're withdrawing from barbiturate, from alcohol, from benzos, any of those things, withdrawal seizures are possible, and that's what you got to be really cautious with and make sure you're monitoring for. So, let's see. We've already gone for an hour and 10 now, and I got, let's see, 2 more sessions. I got 4 more hours before we actually do our review. So how many more slides do I have? I got a lot of slides, but I think we did a good amount of work here today, going for 70 minutes now. So do you have any questions? Please put those in the chat now. I'm going to look on the sticky board to see. I didn't see anything about the belladonna alkaloids. Belladonna comes from the term they used to use for beautiful ladies. They would actually use anticholinergics in the eyes. They'd actually place these compounds in the eyes, and it would cause mydriasis, and that was thought to be very beautiful back in the day. Yeah, and so it was, I imagine if I were to go on a date and someone had big saucer-like pupils, I would say, you seem like you're on drugs. This is not going to go well. So there's that. Anyways, let's see. Side effects of spironolactone. I may have got additional potassium, impotence, menstrual irregularities, hirsutism, gynecomastia, acidosis, peptic ulcer, and last but not least, the mnemonic itself states the main side effect, hyperkalemia. Interesting. Recently learned in Guyan that spironolactone is used to treat hirsutism in females with PCOS because of anti-androgenic effects. However, I saw this image shared on a medical page saying spironolactone causes hirsutism. Is this true? If so, can you explain? Yes, that is true. I can explain. And I will. It has to do with kind of what the resting state is for androgenic effects in that particular patient, right? So, for instance, if someone has PCOS and are in a hyperandrogenic state, right? So they have too much androgens around, like testosterone, DHT maybe. Spironolactone being a partial androgen receptor agonist can help drop that effect down, right? So if they're having too much androgens, we can drop that down and decrease that effect. Just like in male patients who have a resting or higher resting androgen levels, that will also cause gynecomastia in them, right? Because you're dropping down and causing more estrogenic effects. For females who don't have PCOS and maybe they have relatively low androgen levels, and then all of a sudden you bump them up with that partial androgen receptor activity with spironolactone, it can cause hirsutism, right? So you got to see where the resting state is at, where you're putting them at when you give the drug, and that will explain the side effects, okay? Hopefully that makes sense. Let's see. Emily says, did you say there are no antidotes for muscle relaxants? There's not really anything good for those other than the tincture of time, unfortunately. Yeah, the only sedative hypnotic one we have an antidote for is flumazenil for the benzos. So let's see, any other questions or anything I can answer for you all on this wonderful Friday afternoon? I'd say go out there and do something fun, but we're not supposed to do that. So I would say stay at home, stay safe, stay sane, and I will see you all, I think, next time.